Testing 1.
Testing 2.
Testing 3.
Testing 4.
Yes.
Brilliant. Smooth, straight in there. Welcome, everybody, to the Testing Podcast, and welcome, Mr. Andrew Coutts. Thank you so much for joining us and coming to... You've travelled a long way as well. Everyone's travelled a long way.
Thank you for inviting me. Yeah, it's been probably 100 miles or so.
Yeah, fair play.
Well,
Yeah,
absolutely.
yeah.
Brilliant.
Could you walk 100 more?
Oh, here we go.
We've not had a...
Only back to Wales.
I don't know where that one is.
Scotland, maybe.
There we go. But Andrew, thank you so much for joining us. Really, I'm really looking forward to this conversation because you've been doing some amazing work and research in the male fertility space for maybe to you also feels like what's been forever.
Yeah, it feels like it.
And getting your PhD done. It's kind of, I've only known you for probably the 4 years that we've been running Test Him.
Yeah.
You and Mike could go back a little bit further.
We go back.
Gosh, how many years? Many moons ago. Many moons ago. We've been talking a long time about fertility and male fertility, haven't we, Andrew?
Yeah.
But also you've kind of been involved with the industry for quite a long time as well, haven't you? Really?
So probably going back at least 15 years, I suppose.
Yeah.
Right.
I mean, my particular fertility journey stretches back 25 years ago.
Goodness me, right.
So my wife and I were trying for about 6.5 years, I suppose, unsuccessfully. And then we booked our treatment. We had some tests, booked some treatment. And then a couple of days before we were due to start our treatment, my wife said, I really don't feel very well. And pregnancy was not on our radar whatsoever. We'd totally given up after 6 years. But anyway, she went and she said, I think I'll better take a pregnancy test. We thought, we'll try it. And she took a test and she was pregnant.
Oh, wow.
And that was 3 days before we were due to start treatment.
Oh, my word.
Unfortunately, the pregnancy went well and we had a daughter. And then 12 months later, she was pregnant again, naturally, and we had another daughter. So that was our particular journey and how it started. And then after that, I'd sort of started to get interested and was talking to other people that have had sort of similar issues. And then sort of, I suppose, naturally evolved into sort of going into the fertility sector. And I formally sort of joined it about 15 or 16 years ago, working for a charity on the business development side. So essentially I was going in and trying to raise money for the charity.
Yeah. Wow. And that's how we met, isn't it?
And that's how we met.
Yeah.
Because you're trying to raise money.
Knocked on my door and said, oh, are you working in the fertility? Oh, yes, I am.
Have you got some money?
Have some money, please.
How many people knock on your door?
Well, in fact, they do more now than they had ever done. So, but no, I mean, it was a great sort of introduction, really, to understand from our side a little bit about what the charity does and what the mission was, and how you can support many people are in the sort of circle that are trying to conceive. And it sort of blew my mind at that time, the impact that the charity was doing. I mean, it doing some great stuff, wasn't it?
It was interesting at the time. I mean, it's not that long ago, but even when I joined the charity, it was totally pointed in the direction of the females. So even from a logo perspective, for instance, their logo was pink coloured.
Yes.
And all of their materials were pink coloured, and they were firmly focused on the female.
Yeah.
And male fertility wasn't
even on the radar, was it? Really?
Absolutely.
No.
It's interesting, and that isn't that long ago.
No, exactly.
No.
Yeah.
Exactly.
Yeah. So, but yeah, I think when I look at what the charity work now does, and there's a few charities in the UK now that's sort of focusing attention, and I think it has differentiated, hasn't it? I think the male side of the research, the voice of the men, the sort of the issues that men have and the support that they need has changed in the minds of physicians, but also the community that charities need to address.
Yeah, exactly. And I think you've got individuals now who have got good public profiles that have come forward and are not afraid to talk about their infertility. Yeah, and that's really moved the dial on, I think.
Yeah, and I think that's where you two boys came involved as well, isn't it? Really. So if you look back about the advocacy, male advocacy, looking at how men can, sort of be a forerunner, really, I suppose, of actually telling their story and then normalising that story for many that may be going through the same sort of battle, and actually giving that support. So you two guys were instrumental of being the first, I think, the very first advocates through a charity to provide support to men.
Yeah, it's a bit weird. There's a lot happened since those days.
Yeah.
Isn't it?
Yeah.
It's strange how that catalyst of the charity
Yeah.
and the fact that they did want to have a voice, and for the men, and they invited us to set up the support group, and bang, off it went. And I guess for you, sort of say 15, 16 years in the industry, kind of, you've seen a lot change in that time, do you think?
Yeah, I mean, it's really changed. I mean, again, from my own experience, we started our treatment within the NHS, for instance. And as you said, it's not that long ago, but they didn't, for instance, have any facilities at this hospital in which I went, which is a major university hospital. They didn't have any facilities, for instance, for me to give a sample.
Wow.
25 years ago, sorry. So I had to go home, do it, and get in through the rush hour traffic to the hospital.
Yeah. How stressful that is.
Many a man has done that. Yeah.
Blue light you sample in.
But I remember asking at the time, well, would you have any objections if I went into the nearest toilet and did it? And no, you can't do that. You just have to go home.
Wow.
That was, it wasn't long ago.
No.
Yeah.
So things have changed in that respect.
There are some very good masturbatoriums out there now.
Oh, yes. Yeah.
I love how they've just been branded the name Masturbatorium. I think it's a support group.
Yeah.
But equally, there are still some very bad ones.
Yeah.
There are still toilets.
I can tell you a few stories from my research on that.
Well, that's
But-
one of the reasons we've got you in here.
why we
isn't
are,
it?
right?
You know.
Because we want to change that shape, don't we? But if people don't know what they're likely to experience, then we want to actually shift that paradigm, don't we? We want to make it more comfortable for men to actually go and provide a sample and feel okay about it. Actually, that's what the key thing is.
Yeah. So I don't want to get too far into your PhD just yet. I want to kind of fill the gap really. So obviously you were then working as a sort of business development within the charity. Kind of what was like the next steps for you then? Obviously that's now some time ago.
Yeah, so the next step really was that I was stretching out to businesses and also to clinics. And at that time, I started visiting clinics outside of the UK. And again, at that time, there was a massive difference between non-UK clinics and UK clinics. Just the way they looked after patients, the cost of treatments at the time. And I realised then that, perhaps patients weren't accessing appropriate facilities. They were going down the NHS route, and then if they were lucky, they may, or if they had the ability to pay, they could go into the private sector in the UK. But at that particular time, not many people were travelling outside of the UK for treatment. And I started to build up all of this knowledge about what was available to people from a non-UK perspective. So then sort of started slipping into that sort of field by just sharing information to patients and talking about clinics in Spain and the Czech Republic and Greece and places like that, and telling people about how much the treatments were, the success rates, how patients were looked after. And it was interesting. And at that particular time, no one else really was doing that sort of work. So I started the what's now become the International Fertility Company, and essentially that is just an independent company that provides advice and information to anyone who's contemplating travelling for treatment. So I sort of went from being sort of UK focused to sort of international focused, and with an interest in people who wanted to travel for treatment.
And at that time, what were the kind of obviously the advantages that you could see that there was either cheaper cost, maybe better care, etc. But did you find that there was benefit in people travelling, being in one location for treatment for a period of time away from the hustle and bustle of life? Was that something that was of benefit to people of why they were choosing to go abroad as well?
Yeah, I think there were a number of reasons really. I mean, cost was at that particular time, cost was the main driver because there was such a big chasm between the UK costs and international costs. There was also cultural things in play as well, because we were having lots of people in the early days that They didn't want to tell their family and friends about them going through IVF treatment, for instance. So they'd quite happily go away and disappear for a couple of weeks.
Okay, for a holiday.
For a holiday,
Yeah.
and have treatment at the same time. So
Yeah.
you had sort of examples like that. But a lot of it at that particular time was cost, I think.
Yeah.
And also there were a group of people who had gone through the NHS, had gone through the private sector in the UK. They were told at that point there was no chance of them ever getting pregnant.
Yeah.
Or they became too old and they couldn't access treatment in the UK, for instance. So that's when they looked at other sort of non-UK options.
Yeah. And there is a big variance, isn't there, between what can be offered in the UK, because we're very highly regulated in the UK with HFEA, and there may be some less regulated countries that can offer different treatments or personalised treatments that often you may not be able to get access through to in the UK as well. So there is definitely variance depending on which country patients wish to use. But you specialised in that. You actually went and vetted quite a number of clinics across Europe, didn't you?
Yeah, and not just Europe, really. It's sort of globally. I think at the last count, I personally visited about 300 clinics worldwide.
Wow.
Yeah.
From a patient's perspective.
Yeah.
So going in and looking at and talking to staff, talking to patients,
Yeah.
and just finding out what those particular patient journeys look like.
Yeah.
That must have been fascinating. Yeah.
Yeah.
Absolutely fascinating.
Some good ones and some really, really bad ones.
Yeah, I bet.
Yeah.
And there's been a lot of growth, I think, over recent years in terms of people accessing treatment overseas. Do you see that the drivers now are the same as they were back then in terms of cost, or is there more to it now, or is it completely different?
Yeah, I think it's completely different now. That big gap in terms of cost between UK and non-UK isn't as big as it was 15 or 16 years ago.
It's still a gap, though, isn't it? It's still very expensive here.
Still a gap, but that's closing.
Right.
Particularly with the discounted treatments that a lot of clinics in the UK now are offering.
Right.
So that gap is closing. But also the composition of patients is also changing. So as I said, 15 years ago, potentially the typical patient going abroad would be someone who's looking at non-UK treatment as a last resort. Now you're seeing a lot more younger patients coming through that can't access the NHS. They can't really access UK private treatment because of the costs. So they're looking at countries like the Czech Republic, for instance, and Cyprus, which are much cheaper. So they're going there as a first choice rather than as a last choice.
And I think it's right to say that the NHS, there are huge waiting lists, waiting times, depending on where you are in the country as well. And I think that's another big driver where patients are thinking, I can't really wait that long. So what is my other choices that's available? And often some of the healthcare is provided by exactly the same physicians, but in a private setting. So they're going like, well, I don't want to waste my opportunity in the NHS. I'll have that, but then I might just go and explore options in another country and then come back appropriately. So there's a whole rack of different reasons, isn't there, for patients wishing to travel abroad for treatment.
Definitely. And things like egg donation treatments, for instance. Again, because we've still got a terrible lack of donors in the UK.
Yeah.
And people do most of the people that I help at the moment are going outside the UK for donor treatments.
Donor conceived. Both sperm and eggs. No, absolutely.
And where did your interest in male fertility kind of come in to all of this?
Well, I suppose it's going back those 25 years. So the issue was my issue. So I had I'd built up a sort of a knowledge of how it could affect an individual. There was also the experience of working for a charity that at that particular time, as we mentioned, didn't really support men at all. And just seeing, and then off the back of that, talking to more and more men over the years, again, confirming the suspicions, long-held suspicions about, there just wasn't any access. There wasn't the information out there. There wasn't the treatment out there. There wasn't the understanding out there. So it was a combination of different factors, I suppose.
And so then you decided, I'll do a PhD.
As you do.
As you do. As people that do PhDs say,
your
as you
international
do.
jet setting and reviewing all these clinics on patients' behalf.
Yes.
But
So I had sort of the odd couple of hours a week.
the odd couple of hours.
And it sort of I started it during lockdown actually.
Okay.
Again, because my business at that particular time was travel, and I just couldn't travel anywhere anyway. So I decided, well, I don't know how long this is going to go on for. I'll start a PhD, and why not in male fertility? Because that was my passion.
Yeah.
Which was also when we started the support group.
Yeah, exactly.
Yeah.
Exactly. Same time.
Right.
So,
is that related in any way, shape, or form? Was there kind of this conversation and you?
It's when we first met, I think, though, isn't it?
It was actually. Yeah, we first spoke at that time.
I remember the conversation about you starting that PhD and where you was at, and I was like, wow, it's a big chunk of time to commit to. But credit to you to do that.
Yeah. Fast forward 4.5 years, and here we are now. In a testing podcast studio.
Just before we started COVID, when we were having discussions about the gap of resources available for male diagnostic testing, wasn't there? So and I think COVID sort of slam dunk there's any sort of progression at that time, but that was a discussion that we were actively having about if patients are going to go abroad, is there some reliable site that we could offer that they could come and do their diagnostic tests and share those diagnostic tests with treatment options abroad? But COVID stopped a lot of activity, didn't it? In its tracks.
A weird time, wasn't it?
Yeah,
very weird time. But I suppose in the good end of the COVID and the pandemic allowed men to get a voice, I think, because the support group that we created in 2020, I think had you started that as a face-to-face in a pub, I think maybe no one would have turned up. But I think our first night we had 24?
24, 25, something like that, yeah.
And we were blown away. We thought, if one or two comes on, it'd be great. And we were like, fucking hell, we got loads of blokes on here. But I think that was a catalyst for us, wasn't it? Is getting men talking, actually, in light of a really bad time for the world, for fertility in some respects, certainly for men, it kind of spurred a lot of conversation, a lot of movement. You may not have started your PhD had the pandemic not happened.
We may never have met.
We may never have met.
None of us may never have met.
Yeah. You may never have learnt about DNA fragmentation and varicocele.
Yeah, because that's exactly how I kind of got diagnosed in the end, wasn't it? It's understanding. I remember being on support groups to sort of fill you in. We had Jonathan Ramsey on one night talking about DNA frag, oxidative stress, varicocele, etc. And I remember just sitting there going, "This feels so very familiar. This does. I've got a lump in my nut and." Like achy balls, and I wonder if this is me. And I think I was texting you either during or afterwards. I was like, I think I need to get tested, mate. and that was the catalyst for me getting diagnosed, wasn't it? Kind of a lot to thank in a weird time that it was.
Yeah. I mean, without being too controversial, COVID, I think, was one of the best things that could have happened to male fertility. Because before that, men particularly, found it very difficult, as you said, just to sort of go anywhere face to face and talk about issues like infertility. And then all of a sudden they had this online access that they could talk to other people. They didn't necessarily need to see them. They could switch the cameras off. That was a big step forward, I think.
Because in the early support groups, actually, we only had maybe a handful of people that jumped on Zoom. Maybe if they are used to doing it through work or whatever, and we're happy to show their faces. But we did have quite a lot that were off. And throughout the sort of hour or 2 hours that we had the support group, you slowly started seeing like cameras blink on.
Coming on.
And even now when we get kind of newbies come on our support group now, you do still find that happens. Guys probably reluctantly go,
the wrong mute and the
wife's got me on here and I'm
just listening in the background.
You
can see who they are, but and you go
you say that,
bring them in.
Last month we had 3 newbies and every single one of them had their camera on from
they
the
did. It's definitely changing, isn't it? I think men have been a bit more empowered to talk now, but you still see that attitude of like, I'll jump on quietly, I'll just listen, and then they go, do you know what, this is all right actually, can I say something? And then they pop the camera on and
all 3 of those newbies actually they all had shared some of their stories. They're incredibly brave, the first time that you join a support group, an established support group as well. In many ways, there's quite a number of people that will come on, month after month, won't they? And provide some fantastic support. We've got some really, really good advocates on there, haven't we? That will support people through their journey, and the ability to bring new people through and take them through, some of the experiences that other people have had is just fantastic. It really is fantastic.
So, how did you shape your PhD? What did you want to do, well, I'd imagine what you wanted to do and what you've ended up doing are probably two different things,
Yeah,
I'd imagine, with
yeah.
research. But what was your vision when you kind of started saying, okay, I want to do this?
So the original, the short answer to that is that it's completely changed.
Yeah.
Completely changed. But the original intention was I had this sort of fanciful idea, as it were, that I could, by research, create a male framework that clinics could adopt that would satisfy all men going through treatment. And the way I thought I would do it was by something called experience-based co-design. And it's a research method that's used in the NHS ordinarily. And usually it's undertaken in a single environment. So it might be a clinic environment where people come in, and you talk about their experiences, whether they're good or bad. And then you get those patients to contribute to the development and the creation of a better service that would help other patients in the future. So that was my original intention. And to do that properly, you had to go into a clinic. My interest was the private sector, because, as you probably know, that 75% of all cycles now are undertaken in the private sector. Without a huge cultural shift and without an injection of money, I think that percentage is going to go up, certainly in the short term. So I wanted to make sure that I wanted to do some research in the private sector, because more and more men would experience fertility treatment in the private sector going forward. Yeah. So I approached some clinics and some clinic owners that I knew really well. And I said, look, I'm doing this research. Can I come in and observe and question some of your patients? And they said, yeah, you can come in, but before you write anything, we want to know exactly what you're writing. And we want the power to edit it.
Yeah, of course they do.
Of course they do.
And it's all about, obviously, competitive advantage. They didn't want to be seen in a negative light. So that sort of quashed that idea that I had. So I had to go back to the drawing board then. To look at other ways that I could gain a bit of a better understanding of male infertility, because that was the crux of the research, really. There's very, very little about men's experience of infertility. It's got better over the last 10 years or so. There are some good pieces of work out there. Not a great deal in the UK, surprisingly, and very little in the private sector. So that's what I really wanted to get to grips with, is actually work out and understand the emotions that men had at the point of diagnosis, if there ever was a diagnosis, but also their experiences of treatment in the treatment centre, good or bad, and then ultimately perhaps come up with some form of care strategy, care framework that going forward. So that was the original intention. Obviously blocked then. So I then sort of looked at other ways of trying to capture that information. So decided on a two-phase approach. So I did some semi-structured interviews with individuals. So I had some basic questions, but I did let individual participants go their own ways. So I was quite sort of flexible and let the conversation go in different directions.
What the dialogue's going to be, yeah.
And then the second phase of the research was grabbing all of that information and putting some sort of structure behind it and getting that to shape a number of focus groups. So there were focus groups in the second stage, and I got a different group of men in, and I said, look, these are the experiences of some of the men I've already interviewed. What do you think about it? Yeah. Do you agree with them? Do you disagree? Will that feedback influence any sort of decisions that you might make in terms of that, developing that sort of framework? So that was another useful exercise. But again, once I was having a look at the data that came out, I had this, as I said, idealistic idea that at the end of the day, I could come up with a 12-point plan that would be appropriate for all males going through treatment, and that wasn't the case. Unfortunately, there were so many diverse experiences from men, and it was really difficult to just put them all on paper and say, right, this is the a framework which characterises all men's experiences going through treatment. And it just didn't work.
That's life, isn't it? Everyone's got their own perspective, their own experience.
Exactly.
There's going to be so many variables.
Exactly. So I ended up with, I think, something like 250,000 words from those focus groups and interviews which I had transcribed. And I really, at that point, the PhD could have gone off in
different ways.
A dozen different ways. So I had to sort of think of what might be the most appropriate to the men that I interviewed and the men that participated in the focus group. And the thing that really came through, and the thesis that eventually concentrated on, was the fact that men now, or the men that I interviewed, were obviously they were in the private sector, and they now viewed themselves not actually as patients but as consumers. And what they were doing at this point now within the private sector is that they were driving forward their personal agenda. They felt that they were paying for a service that they could have a much firmer control of, and they weren't sort of being led by clinicians. They were in a stronger position within the private sector where they could have a certain level of control over the management of their care.
Okay, that's what they thought.
This is what they perceived. So they believed that they were in a position that they were paying for a service, and if that service wasn't available, then they had the right to go out and seek
agency to go and do
additional services. So a lot of the men, for instance, which is no surprise to all of us, I'm sure, went into a clinic. Originally, the conversations were very transactional because it was a business-like relationship between professional and patient. They were being led by a clinician, very, very transactional in the sense, we're going to do this, we're going to do that, we're going to do this. And then as time progressed and when treatments paused or were unsuccessful, men, I think, then realise that, look, I'm in the private sector here. I'm paying for a service and I just haven't got it. I've not been tested. I've not been given the treatment options. So then the men in the thesis have gone out and they've sought those options themselves. So it might be going to an online support group. It may be going to a specialist who works in male fertility. And so that's their whole journey has now been driven by the fact that they believe they are consumers. And as consumers, they've got a bigger say in their management of their care.
And do you think that has come about through disappointment in the way in which they had an interaction in that private sector right at the beginning? Or do you think that through some of the questionnaires that you were proposing to them, they sort of had that light bulb moment and go like, oh, I didn't realise there was a choice, but now I reflect on it, I am a consumer, not a patient, and move forward. I'm just curious about how your your PhD may have shaped their thoughts and sort of.
I think for my group of men, the trigger was actually interaction with other men through external groups.
Right.
So they weren't getting that feedback internally. So the vast majority of people I interviewed had used or had interacted with groups outside of the clinic environment. But they weren't this is one of the interesting things. They weren't necessarily going to those groups, or the majority of them weren't necessarily going to the groups for emotional support. The vast majority of them were going for information. And they used the interaction with those groups to go back into the clinic. They were more confident.
Empowering
and
themselves.
They were able then to, in a way, be self-determined, I suppose. They could actually go in and now rather than being led by the clinician, they were going in empowered and saying, I want, can't you investigate, this aspect of my infertility? I want this type of treatment. If you're not going to give it to me, I'm a purchaser. I'll go and buy it myself.
Yeah, this is my credit card. I'll take it elsewhere.
Exactly.
Yeah.
Exactly. So they were going in to that interaction was the really empowering thing with the groups.
And did that information that they gathered and then positioning themselves that way in a clinic, did it allow them to actually then get what they want? Did they feel like they were getting the right treatment or getting what they wanted?
Pushing for it.
And getting, the support that they wanted, and therefore potentially a better outcome, or if they didn't get the better outcome, that they at least felt like the journey was better.
Yeah, exactly. That was the overriding opinion from the men. They went in. They re-entered the clinic confident, and whatever the outcome was, the eventual outcome was, they felt that they had done as much as they could have done.
They could have done.
And that's such
so
an important part.
We always say.
My goodness, yeah. I mean, that information really needs to get out. I mean, it'd be great to have that, synopsis, I suppose, once you've got it, because I think there's a number of papers that you were talking about earlier before we came on the podcast, because I think what that insight has given you is that men need to know, as we were talking about this earlier on, men want to know how to fix things, don't they? And when you're going through a fertility challenge, they want to know how to fix it. So not be told, this is what's, this is the menu and this is what you're going to choose from, and this is what you're going to pay for. They actually want to know what are my choices, what are my options, and to get that independent sort of advice from peers, from a support group or whatever. It may not be that they're wanting that emotional support. Maybe they haven't got through that first phase of maybe having a cycle and the cycle not working and so forth. They might not need that emotional support, and they may need that emotional support. But in order to sort of like frame what is my expectations of going through a fertility journey and through a fertility clinic, how can I make that better? Because it's, as you say, it's transactional. Actually, it is transactional, but it's personal because the men want to fix it, don't they? Mm-hmm. So, interesting. Mm-hmm. Very interesting. So we need to do a bit more then, Andrew, don't we? We need to explore what you've uncovered, because I think it's an important thing, because there'll be a lot of couples out there that won't necessarily, for the first time, they may be struggling. They may have had some basic tests at GP land, but then they're automatically getting pointed towards that assisted conception unit, aren't they? And there may be things that they can do before that, and maybe joining a support group and exploring, and asking questions in a secure and healthy environment. Maybe they're a better choice rather than going to see a physician, which is going to guide you to IVF. Yeah,
of course. I mean, as I said, the men that I interviewed didn't come up with a complete framework for male-centred care, as I was hoping it would. But there were lots of commonalities between their experiences and their desires and their wants. So one of them certainly was in early intervention. So when they were going into clinics, they were talking to people really with, in most of the cases, quite limited support and limited knowledge in terms of male fertility. So early intervention was the one thing that absolutely everyone mentioned. Wow. Everyone mentioned early intervention. And the fact that, and lack of resources was another one. Interestingly enough, when I asked them about whether, in terms of that support inside the clinic, whether they would have preferred male or female support, someone, a man or a female delivering that support, the vast majority of men said, we don't care, actually.
I've heard that before.
Yeah,
so
we've heard that before, haven't we?
Yeah.
Who don't actually care. They just need that level of support.
Yeah.
You need someone who cares. That's
care.
That's
exactly. It is about that, somebody that cares and that can explain what's going on.
Yeah.
And again, again, from my initial thoughts, I thought men might say, we don't mind if it's a man or a woman supporting us, but we might want that support alone. But the vast majority of men said, actually, no, we want that support together with our partners.
Yeah.
Which again, was slightly different from what I was expecting.
I think that's an important thing, isn't it? Because you need, as a couple going through that journey, to recognise each other's weaknesses, vulnerabilities, and understand, is the male factor involved here, female factor involved, or is there a complex sort of blend of the two? So to actually get that level of support and look at options, people can then make the right choices together. And I think making the choices together actually keeps people together through that journey and manages those expectations.
But the fascinating thing was, though, that inside the clinic, the men said they want that support alongside their partners. Mm-hmm. But when they sought support outside the clinic, they wanted to do it alone. So they didn't want to bring their partners along to a generic support group. They wanted to go alone to a male dedicated support group.
That's interesting. That's very interesting.
I wonder if part of that is because when they're in the clinic, a lot of the conversation is about the woman. and the woman's name is called and the notes are in the woman's name. And so maybe the guy, I wonder if that shapes the guy's experience of when I'm in the clinic. I want the support to be about both of us.
Yeah.
But I also want something that's just for me separately as well.
Yeah, I mean, one phrase that came up again and again was that men in the clinic feel they are not reproductively complex or complex as the woman because they've been told they're not reproductively complex as their partners.
That's really interesting.
So that's that's being reinforced in a lot of times by the clinic itself because, as you know, the woman is subject to the most tests and the most consultations, and a lot of the men, the more time they spend in that environment, they come to think of themselves as being not reproductively complex. I mean, and it's not until they then access dedicated specialist information outside of the clinic that they think, oh, yeah, well, perhaps my issue is quite complex, and
there's a lot more.
There's a lot more that could be going on, which I don't know about.
Yeah, and that resonates so much to me when I went through my journey. That really the only focus for me is if we can get some sperm, we'll do ICSI, and I ended up having sort of ICSI as part of the journey plan, and that was it. There's no other further investigations, and I had to really push after we'd had a failure to go and check the competency of my sperm, which was stored with the clinic, and they were highly sort of resistant to do it. They said, well, we'll just do another gold standard, through the Rolls-Royce activities in. And I went, no, I think we just need to go back and just see if we can find out if there's something wrong there before we start going again. And there was. It's those types of things that those experiences that you have with clinics. Don't accept what the doctor's just saying to you. Get support externally. Just verify it. Get a second opinion. And so often the peer groups that we've got, and there's quite a few peer groups and specialist male for peer groups. Go and get some peer advice and just check whether you're being told the right thing, or if there's other things that you may want to just go back and just fully explore what you're doing. But so insightful, Andrew. But
I wonder what that narrative does to a man's psyche of you're not as reproductively complex as your partner. What does that make a man feel and think about himself? Does he therefore think, well, actually, I'm not that complex, there's not much I can do? Does it disempower them? Does it make them feel inferior? Did that come up in conversation?
It did, and I think if you look at a lot of academic research in the past, men got to that point. They were told that that probably is the case. That the clinic perhaps wouldn't be able to offer any alternatives. It was just natural for the woman to receive the majority of the care and treatment in the environment, and that's why a lot of men just took a step back. They accepted their invisibility within the clinic environment, and just saw that as being inevitable. And it's not we're looking at sort of wider than the clinic environment at the moment. We've got all of the groups that are increasing men's visibility generally, and I think that's given men now the impetus to actually start questioning and things. And that's why I went back to this idea about consumerism, because it is tied to masculinity and how men feel about the treatment in the clinic, their emotions, and it's going back to the position of it's giving men a lot more power within the private sector, particularly as a consumer, as a purchaser, and that's given them the confidence to do it. I mean, the downside of this is that obviously the people that could benefit from being in that position are only those people that could have the ability to pay for it. So as the NHS is shrinking and shrinking, there are people still heavily reliant on going down that path, their only path, and they're not going to benefit from this. 10 years down the line, they may have to, because what's happening is that obviously the men are driving, to a certain extent, the quality of care because they are purchasers of a service. And equally then the clinic have got to respond as a supplier.
But are the clinics responding? That would be the other question. So these men that are going in and voting with their credit cards and saying, I want X, Y, and Z, are the clinics actually responding to that?
From the limited experience I have, there are signs that they're having to respond to it, because men just will talk with their feet, and then if they're not getting that service quickly and effectively, again, as a purchaser, they can go to another clinic.
Another clinic. Yeah.
So in a way, the clinic's hand is being forced. They may not necessarily want to do it, but their hand is being forced, and ultimately, fingers crossed, for those people unfortunately who can't access that treatment because of financial needs, that clinics providing some more quality driven service, hopefully that may cascade down into the non-paid sector, and ultimately that may improve the quality of care for other men who can't pay for treatment.
I mean, we see many men, don't we, on this support group now, and many of them are sort of locked into that NHS pathway because that's the choice that they are in at that time. They don't necessarily have a choice of going externally because of funds entering the private sector. So they're often in that waiting queue to be seen, and they're asking, what can I do whilst I'm going through that sort of process? But equally, people that may need to go into that private sector, there are other ways, and I think you've been working in those other ways, where these out-of-pocket expenses for consultations, maybe for diagnostic tests and pre-treatment options prior to IVF, these are so important. But there are insurance companies now that are offering these types of benefits through employment schemes and so forth. And a lot of men don't really realise that within their own employment that they may have a employer assisted program or something like that, or a health program that is an health insurance that they can access, that may take some of that burden across. But you're doing some work in that area. I don't know if you want to elaborate on that.
So I've been sort of doing some work for about a year and a half now for a US company that work with employers to offer employees access to certain treatments. It's quite an active market in the US. So the company I'm doing some work for at the moment, the longest established company there, they've been working for 30 years. The UK market is quite immature, obviously compared to the American market. But employers, if you talk to employers, and we all know the negative effects that infertility can bring in terms of the practical and the emotional. You go to employers and say, look, your employees would be a lot happier if you were able to offer, even if it's a limited form of support for them, whether it might be time off for appointments, whether it might be financial contribution towards treatment costs. And employers now are coming around to the idea that, for a small investment, they could make their employees a lot happier. And I think that that culture is just beginning to take off, not necessarily in fertility, but certainly in other health areas. So in oncology, for instance, there's lots of employers that will provide assistance for people going through cancer treatment. Yeah. But I think fertility is catching up, and there are more employers now that are looking at offering those sorts of benefits to employees.
Yeah, and I think our shout out is that if you are employed by an organisation that does have a plan, have a look, speak to their HR department and see whether consultations or support, maybe counselling or something like that. If people are struggling with their fertility journey, it's often available in that sector and at no cost, because the employer is already paid for that as part of your program. So it's definitely worth seeking out whether you're covered, and if not, you're not covered. Badger your HR department and say, bloody well should be. You're offering benefits for your female colleagues, but not for men. So I think that's one of the things that we badger on about.
Did that come up in the research much as well, in terms of work and work pressures and that side?
It did. A lot of the men were saying how difficult it was in terms of just finding or getting time off work, for instance. Interestingly, they didn't talk a lot about having conversations with their work colleagues, for instance, or they did at a point of their own choosing. So again, it's all going back to having a certain level of control over the whole experience.
And what else were some of the common themes that came up in the focus groups and one-to-ones?
Obviously, going back to the giving of the sample. I mean, there were some horror stories there. When you've had individuals who are asked to give their sample in the room that the consultation is being held in. So where the clinician will say, your partner and I will disappear for a couple of minutes, get on with it, and we will see you in 5 minutes.
Go around the curtain.
Wow.
And,
So we've had things like that. We've had instances where men have had to go into a corner of a room which has got a leaky roof, for instance, and one person is in a room giving us its sample when the people are cleaning the windows.
Oh, no.
Oh, my word. Yeah.
Oh, wow.
So there's some really, really sort of horror stories in terms of samples.
Good God. And you must have inevitably got into the emotional impact as well as part of this research.
Yeah. I mean, interestingly, it's interesting how long-term negative emotional feelings persist. There's one or two men that all of the men I interviewed had gone through treatment in the last 5 years, but there were some men that were really at the end of the journey because they'd been through 10 or 15 years of treatment, and it was significantly impacting on them. Even after that length of time.
Yeah.
So it's not transitory. It can be transitory for some men. And again, this is really interesting. Talking to some of the men, I asked about how they felt at the end of their treatment. Some men had really, really bad experiences, but the treatment was successful. And they turned around and said, I've advised a couple of friends to go to that clinic. And I said, well, your experience was really bad.
Yeah.
And they said, no, but we got what we wanted. We paid for a baby, we got it. So they were happy to advise their friends.
To advise that transaction.
It's a difficult one, that, isn't it?
It's a really challenging one, isn't it?
Yeah, you're right. The success is obviously the outcome of having a baby, but if you've got what you've paid for, that of course you can kind of recommend it, but that's interesting that you've had a bad experience and yet you'd still recommend the clinic. I find that quite wild.
That was one of the most surprising things that came out, and it wasn't till one person. Multiple people said the same thing.
Yeah,
interesting. And what about the kind of the emotional effect? Even though they've had a live birth outcome, did you sort of look at the post birth, post baby? Do you still have trauma, or is there still kind of like that kind of emotion kicking back up? Is that common at all?
It wasn't something that I covered in this piece of work because I think that warrants another PhD.
I think you're right. Yeah,
you said you've got a couple of hours.
Go on.
Now.
This next one.
In between shifts, Toby. Just start writing some things up. Yeah.
But yes, I mean, again, there's so many interesting aspects to this that could warrant their own PhDs. And I would sooner not try to cover an aspect like that because I wouldn't be able to do it justice.
Yeah, you'd want to give it its full attention. Yeah.
It is a PhD in itself, I think.
Yeah, definitely.
But both for men and women, but just purely on the male side is what is the impact of infertility on a man, whether he has a child or doesn't have a child after treatment. But I think we've touched on this a couple of times now. Is having a child after fertility treatment is not. It's not okay. It's all fixed now. It's all okay.
Yeah. Well, often the clinics hand over all of that responsibility back to the general practice sort of thing to carry on, and actually some of that trauma and some of the experiences, I know as a patient, I wouldn't want the same experience that we experienced in that clinic. We would want to see that improve, and then I think there is room to do that, isn't there? I know that you, as part of your PhD, you were looking for feedback. You're trying to explore, what the emotional sort of journey and various other characteristics of it. But the HFEA do try and get feedback as well, don't they? The regulator in the UK to try and improve the standards right throughout the country. But I don't think there's enough of that really. What's your feeling there?
Yeah, I mean, it's interesting because going back to the international work that I do, we are, as you said, heavily regulated in the UK. And I think for that reason, as a patient, I feel perhaps a lot safer than if I was in another country. I think going back to my work, obviously we've spoken about sort of some negative experiences that men have had, but there's also been some really good and positive experiences,
Brilliant.
particularly on the emotional side. So I don't think all of the clinics that I think overall there are 16 clinics that were involved in the study. And certainly not all of them were bad clinics.
No. And we're
so
not
there's-
here to
no,
bash
no,
clinics here whatsoever.
But they are moving in the right direction,
Yeah,
I think.
yeah.
And that's off the back of some of these external groups.
Mm.
You know, they are listening now to the men themselves. They are listening to the external groups.
Yeah, and I think in fairness to clinics as well, I think, you know, society, and I was one of those guys where in the early days of our IVF treatment, I was quite happy just to go there, sit in the room, and as much as I felt really alienated anyway, but the minute I was okay, I was kind of like just a bit of a quiet member in the room. You know, in fairness to clinics, when there's that barrier from men anyway, because we're pretty shit at talking, it is hard for them to go, well, how do we support men? And that's why I think external support groups have been really good for guys, because it gives blokes that opportunity just to kind of like, you know, blow off that steam and let it out. Get them to understand actually what they can then do, so that when they go to the clinic, they can actually help the clinic them as well, because they can go, look, I've worked through various support groups, I've educated myself, and now I can ask the right questions, because I think asking the right questions is really important from a patient to help the clinic in order for them to understand how to then offer that support as well. So again, it's that kind of full cycle thing, isn't it? Like that.
Yeah, definitely.
Yeah, and just thinking about clinics, you know, in terms of the support that they give couples and men, and from some of the insight that you've shared with us today, you know, I think that there's definitely room for improvement. I think right across the board to improve the amount of care that can be offered. And I think right at the forefront of walking through a clinic, which is really, really daunting for couples to walk through there, because they're expressing their full vulnerability, having been referred from their general practitioner. Or it's a self-referral and so forth, that level of care is that, you know, it's care given that these are the options. Before we get into the detail, you know, we think you may need some support. And often clinics are, well, I think they're obligated in the UK certainly to be able to offer counselling as part of fertility counselling, as part of that fertility journey. But there are other non-cost based support and support groups that are there either through the charities, which are absolutely brilliant and fantastic, and that's what the charities are there to do. But there are all other support groups which may be more appropriate depending on the needs of that patient. And as you said earlier on, those patients can be quite complex. They may want different things from different experiences, but having an option of saying these are the resources that may be really useful to you could be really, really important.
Yeah. On the note of counselling, then, were you able to quantify within your cohort of guys, how many were offered counselling? I know obviously it's a mandatory thing to offer at least one, but then of those guys that were offered counselling, then how many sessions were they offered through the clinic? Was that something you was able to quantify through?
Yeah, most of them were offered one session.
Yeah.
And then in the majority of cases, they chose not to continue with it, or they chose external counsellors. So they weren't happy with the quality of the counsellors they were offered internally.
Okay,
That's interesting.
It's an interesting observation, isn't it?
Yeah.
Really?
And was it generally viewed as a positive thing by men?
It was viewed as having access to counsellors was a positive thing, but the access they did experience wasn't.
Oh, that's interesting.
Yeah, but I think it's counselling is quite tricky, isn't it? Because I think the guy needs to find someone that they're comfortable with, and sometimes having your own choice to find that person is what you kind of need. Whereas obviously a clinic, unfortunately, they don't have the resources to have like a library of 10 or 20 different counsellors. So I think it's quite a struggle for clinics there. But it's interesting that majority had not found that positive, and then obviously sought to seek it externally. I just find that an interesting thing, because I'm hugely pro counselling. I had many sessions with a counsellor, and it was so beneficial because I was able to just freely talk and not feel judged. But yeah, I think that's an interesting observation. Is there a way with clinics and counsellors that we can build a better library so that it's not just a kind of just a one person? Because I think that is the problem there, isn't it? Is that counsellor might be a really good counsellor, but it just might not be a personal fit. And they may have been chosen more to look at kind of female-led sort of counselling that's their experience as a counsellor, and that's fine.
Mm-hmm.
But then that doesn't necessarily help the guy. So it'd just be
It kind
curious
of-
to know
each
how you
clinic
can
almost
improve
needs
that.
two counsellors on the books, don't they? One that
I
specialises
think
in women,
more, I
one
think
that specialises in men.
Yeah, maybe even more. Maybe even there's something that they can access where there's like a big cohort.
Pooled.
Well, that's what
Pooled.
Beaker is. But
Yeah.
they can-
Beaker's out there, isn't there, to try and give that level of independent support.
Yeah, I
mean,
wonder what it's like. Just be curious to know from the clinic side, like what is their kind of limitations and how we can, as a community, make that more accessible for choice, so that men do get a better experience, because that's ultimately going to help the clinic out,
Yeah.
and the couple, and it just seems like a really obvious thing to fix, doesn't it? But
I think for overall, not just counselling, but other services that men could have access to, and don't have a good level of access. I think on many occasions, if the clinics were more flexible in terms of doing some collaborative working with external groups, that would certainly improve the situation.
Yeah.
Rather than trying to stretch a limited amount of resources to provide the barest minimum to men, it would be far more advantageous really to work with external organisations and offer a better service.
yeah, I think that's what I'm trying to get at there, isn't it? Because it is a limiting factor, isn't it?
Yeah.
As a there are a business, and there's a cost to offering that, isn't there?
Yeah.
But like I say, if we can, as a society, as a community, make that more easier for them to offer it, I think it'll only be a positive thing, wouldn't it?
And there's many other services, isn't there? It's like fertility coaching or nutritional coaching and things like that, which will have, more than likely to have a beneficial impact on that patient journey and improve the outcomes. I mean, if you're a clinic and you're outcome led in terms of improving the number of live birth outcomes per number of patients that comes through the clinic, then actually offering an array of different services, paid or unpaid, is going to be more beneficial for that clinic to get the outcomes and be more desirable, I think, for couples wanting to enter into that clinic. So that's got to be the choice.
Yeah, because if as a guy your one and only experience is with that counsellor, and then that means you then don't get any further help or don't even seek it. You don't even go to a support group or nothing. You go, well, that was a load of rubbish. It was a waste of my time, just as I thought it would be.
Yep.
Actually, we know that if you get the right match, it's a wonderful thing. It's really important, because the mental health side of this is really important, and even to, like I mentioned earlier about kind of if you have a live birth outcome, if you have a good outcome, you don't want to just patch over that. You've still got trauma that you kind of got to deal with, and I think actually then if you are then a parent, you've then got obviously a challenge of being a father, which is his own new journey. But if you've just patched over the trauma that you've gone through without the right support there, I just think you're really in a really vulnerable position. So I don't know. I just feel like we've just.
I think we just need a postnatal men's group or something like that.
yeah, that needs to be done as well. But yeah, I think from professional help, I'm a huge advocate for it. So. I think that's really uncovered something actually for me to, how can we fix this as an industry and help clinics out like that?
Yeah, and crikey, I mean, Andrew, you've got a lot of experience right across the international platform with clinics. From what you've learned from doing your own PhD and that insight, what would you be telling those international clinics that know you, that may be listening to this podcast?
In terms of what better
the
support?
Insight, the insight that you got,
It's a difficult one to answer, really, again, because it's so complex, and men come at it from different, and they come at it from different perspectives, and they want different things from the guy. To mention, some just want that success of having a child, others want that support from the day one they go into the clinic. I think having access to, either internally, having access to that dedicated, focused material, so people feel that the care that they're being given is being given by an informed person with that knowledge specifically of male fertility. That's one of the most important things, is going in and having the confidence straight away that you're talking to someone who actually knows, understands and acknowledges what you're going, and cares what you're going through.
Yeah.
So I think it's making sure that the initial contact that you have with a male patient, you need to give them that reassurance and confidence, that you do understand, you do care, and there is that knowledge.
Yeah. I mean, I think that's everything that we do, isn't it? It's about education, it's about awareness, it's about knowing your own body, it's about knowing what options you have got for diagnostic tests, it's exploring everything that you possibly can holistically to look at risk factors and know where to be triaged appropriately. And if people have got that right up front, before you get into the detail of that transactional, this is what I'm paying for, then actually the choices become a lot better, don't they?
Yes.
And when men, you said obviously out of the 16 clinics, some men had a really positive experience. What was their feedback in terms of what made it positive? What made the difference for them?
I think it was that they were actively encouraged to participate in that journey from day one. There were some really positive responses and feedback from men where treatment was unsuccessful, but the fact that they were cared for and listened to throughout the journey was enough and was sufficient for them to give positive feedback.
That's awesome to hear.
Yeah,
that's all you want.
That's the simplest thing, isn't it?
Yeah.
That's all you want.
It's compassion, isn't it?
Yeah.
It's empathy. It's being able to sort of come to terms with, that things might not be what you hoped it to be, and that's actually okay, because people can live with that if they know, if they're informed that you've come to the end of the line, or there are other choices which might not be that you can conceive through your own biological ways that you would like to. So
Fascinating research. I can't wait to read all of this. It's
Yes.
gonna be really good. So it'll be published, will it? Or
So we're going through the process now. Perhaps by the time this podcast goes out, it would be done and dusted. But
Brilliant.
so I'm hoping in the next.
you'll be lying on a beach somewhere.
Yeah.
Pina colada.
With a couple of hours extra free in it.
Yeah, but a couple of months. I've got to defend it then in the sort of the online face-to-face exam, and then hopefully it'll be ready for
Are
publishing.
you going to send it to all UK clinics?
Yeah, that might be interesting.
We'll support you. We'll put the postage on it.
Yeah, absolutely.
We know that's expensive.
Yeah. But what comes next in terms of, obviously there's that element in terms of finishing it off, getting it published, but are there recommendations from the PhD? Do you kind of make recommendations of either further research or industry changes?
Yeah. Again, originally the intention was to go and make some firm recommendations. But I don't think it's appropriate at this stage to do that because it's I thought it was a relatively small sample group. So effectively we had about 30 people. Talking to other academics in male research, they were saying, well, that's really good to get 30 people.
That's a good cohort,
I'm not sure that for my own satisfaction that I would like to make recommendations at this stage. But I think there's enough information there in that 80,000 words that other people can, myself or other people can take up and look at elements of the work and position it sort of and give it a practical application. So I was telling someone the other day about how I sort of saw the experience of doing the PhD, and it's like I suppose it's like a bit like a fashion show. So you see these outrageous dresses that these women wear, and you think they couldn't be given a practical application. You couldn't go into Next and buy one of those things. But what they do is they influence shoppers or they influence designers. And I think this is the thing about the PhD. A lot of the content in it hasn't got a practical application. So it is quite sort of academic in parts. But if it can just influence other people, practitioners, other researchers, you've done a job then.
A really positive job.
It's making impact, isn't it, into that, improving that awareness and education around male fertility. And it is a serious topic. We try and make light of it from time to time, but it is a serious topic, and there is a huge amount of improvement out there that can be done, and quite simply as well. Just by listening, caring, and sharing.
But I also think, sorry to interject here, but I also think as well within academia and just my personal experience is that when the people that are very, very good at offering really good support, and I won't mention names because we mentioned many names on here, but I think they're the ones that can deal with on the very much a human level, whilst having a very good understanding of the complexity of you know, fertility
Science,
treatments and stuff, and something like embryology, or you know, and to be a clinician, it's highly intelligent people. You know, it's long years of study. And I almost wonder through their education that actually they can have, through maybe something like this PhD, is that they can actually have rippled into their studies. How do they care for a person throughout? Because I think, I mean, I don't know the whole syllabus, so I'm talking a bit blind here, but obviously there's a huge amount of study that goes into being really good at their job in something like embryology or diagnostics, etc. But actually, ultimately, the data behind that are human beings.
It's the bedside manner, isn't it?
Yeah,
It's the soft skills, isn't it?
It's building that in, yeah. And so, and I mean, I remember from my own personal time at my IVF clinic, the clinician that we saw from day one, or the very first appointment, was like, "You're both young, you're both fit, both healthy. We're going to give you a baby." And it was like almost like a promise straight away. And of course, after the first round, we're like, "You know, that didn't work, did it?" And it's really shit. But I remember the embryologist. She was amazing. She was so caring, and she gave us a hug. And when we left the door after, you know, the first round that wasn't successful, you know, she just sat down with us. Like, "Are you all right, guys? Like, how are you?" And it just felt very human, rather than a medical thing. And I think sometimes that blend needs to happen a bit more. And hopefully the kind of the work you've done here will highlight that to the professional sector. That the humanity side of it, or is that the right word?
Human
side
side
of
of things.
it, can shine through here, because it's such an important part of that whole process. And I think when, you know, we always talk here about kind of, you know, unexplained infertility is undiagnosed, and in the same instance that if as a guy you've explored all avenues and you may not have had the outcome you've desired, it's far easier to move on in your fertility journey and on into life, knowing that you've done everything possible. I think when you get to the end, if you've not had that right level of care and later discover, oh, actually I could have done this, but it's too late now, that's really damaging for a guy. And I know personally people that have gone beyond their life now with not having children. Menopause came, you know, some years later I've met them and they've gone, "Do you know what, after what you've done, it might have actually been me the whole time." And that's become quite a traumatic thing for that person. So I just think your work you've done is incredible, and I think it'll be really interesting just the impact it's gonna have for the whole industry.
It is really valuable, and we can't wait to see it, and we will be sharing it as much as we can. We'll be referencing it. It'll be going on our social media.
Lots more opportunities to get together as well.
Yeah.
So. I know it's been a lot of work for you, Andrew, and huge congratulations. I know you've still got a couple of hoops to jump through to finish it off, but there is still already huge value in what you've done, and it will make a difference to the male fertility community. So thank you, and on all our behalf, and all the men that we've supported. I think it's amazing. So
much.
Yeah, absolutely. And thank you again so much for joining us. And we wish you all well with
thank you very much.
This PhD and the next one.
Yes, and the next one.
Thank you.
Cheers, everyone.
Thanks, Andrew. Thanks for everybody. Bye.